Hello, and thanks for joining us. Welcome to the 2022 American Diabetes Association Ask the Expert series. Today's topic is youth and family, eye care consideration, and other topics. My name is Carla Cox, registered dietitian and certified diabetes care and education specialist, and your host for today's program. Remember that our Ask the Expert series is all about answering questions from our listeners. So start getting your questions ready. For those of you on the phone, press *3, that's *3 on your keypad, and an operator will collect your question and place you in a queue so that you may ask your question live. To participate online, type in your name and question in the fields below the streaming player, press the Submit Question button, and your question will come directly to us. In addition, we invite you to provide us with your feedback in a survey when you leave the event. We use the information to help us plan for future events. Okay, now a little bit about why we're here today. The American Diabetes Association, together with visionary partners, VSP, Vision Care, and Regeneron Pharmaceuticals Incorporated, is focusing on an often overlooked and costly, devastating complication of diabetes, vision loss. The Eye Health Initiative, Focus on Diabetes, provides tools and resources for people with diabetes to learn how to reduce their risk of developing eye disease by managing glucose values and getting an annual comprehensive dilated eye exam, even if symptoms are not present. As part of the initiative, the ADA is holding this free educational Q&A and will cover information and tips to help you take care of your health. We will also broaden that and ask other questions about kids and diabetes and questions that you might have. I am thoroughly delighted that we will be offering a Diabetes and the Family Ask the Expert, and we hope that we will do more in the future. And now I'm delighted to introduce our speakers, who I know both of them quite well. Dr. Blake Cooper. Dr. Cooper received his residency and fellowship training in ophthalmology and vitreoretinal surgery at Washington University in St. Louis. Over the past 17 years, Dr. Cooper has worked in Kansas City caring for complications related to diabetes-related retinopathy. He has a personal and professional interest in improving the lives of individuals living with diabetes. He is the 2020 chapter board president of the JDRF, and his oldest daughter has been living well with type 1 diabetes for the past 8 years. And he just shared that she will be starting medical school today. Our other expert is Chris Britt. He is an RN and CDCES with a diverse educational background. This husband and father of 4 changed careers when his oldest son, Carter, was diagnosed with type 1 diabetes at the age of 6. He graduated with a music education degree in 2006 and from nursing school in 2014. He spent his first season of nursing in a level 1 trauma center and then made the transition to the world of diabetes. His passion for education and a strong desire to help patients and families navigate the often choppy waters of diabetes drives him each day and every day. Chris is a member of ADCES, has served on the ACDES Professional Practice Committee, and is co-founder of TID Revolution. So, Dr. Cooper, do you want to just add a little something to that introduction?
Well, I think it's, very, very sort of flattering, but real reason we're here tonight, at least the real reason I'm here tonight is I understand how difficult it is to have a loved one or to live with diabetes. And unfortunately, in my world, I tend to see more of the sort of late complications of having diabetes and want to make sure that those complications never develop, right? And if we can screen early and treat, I think that's going to be an important message. We're able to help prevent, visual loss. And so for those who are on the call, I'm happy to ask and answer any questions related to the eye health or anything there's pressing or wondering about what it's like to have an eye exam. Thank you.
Perfect, thank you. And Chris, what about you? Do you want to add something in as well?
I think every day I'm reminded both at home and at in our practice that there's not a single area of diabetes. A single area of life that diabetes doesn't touch. And so I just welcome any sort of questions about anything because it just permeates every single branch of life. And I I spend my days trying to make sure that people are okay, that frustration levels are low, that everybody has the resources that they need, and um, you know, just kind of affirming that you can rock this disease. You can rock this. It doesn't have to ruin your life. I even have patients, teenage patients that say, you know what, there's some really good things about me having diabetes. So that's a bold place to go. But yeah, I'm just happy to be here.
Great. Thank you so much. Remember, today's questions are based on the family and children with type 1 diabetes. So when you're asking your questions, remember that's the focus today. So as we are waiting for our callers and online listeners to chime in, I'm going to go ahead and kick off with asking you if you could give us a brief introduction. Dr. Cooper, why are we talking about eye disease with young children with type 1 diabetes?
Yeah, you would. It's a great question. So we understand that diabetes has what we call microvascular and macrovascular complications, and the microvascular changes that can occur within the back of the eye can affect vision, and it's not that it happens overnight. It takes oftentimes years or decades of living with diabetes for those changes to occur. But what's important to understand is that we're able to actually now, with therapy and treatment, actually halt and stop the progression of retinopathy. And so we're able to, with monitoring, figure out who's at risk and be able to slow that process down. The only way that really happens, though, is by ensuring that we're screening and examining patients. Unfortunately, what happens is that when you first get diagnosed, it's sort of overwhelming, right? I mean, I remember when my daughter was 12 and she was diagnosed and she was in the hospital for 3 days. And, being a physician, I sort of understood a little bit about diabetes, but not at all the understanding what it's like to live day in and day out with it, that she's done. But it's one of those things that um, once the dust settles, so to speak, making sure that everyone's getting in for an annual exam, at least an eye exam, is extremely important to, make sure that we have early detection and then appropriate treatment is needed.
Thank you. If you're just joining us, welcome to today's Ask the Experts Q&A, Youth and Family, Eye Care, and Other Considerations. As a reminder, for those of you on the phone, press *3, that's *3 on your TPad, and an operator will collect your question and place you in a queue so you can have the opportunity to ask your question live. To participate online, type in your name and question in the fields below the streaming player, press the Submit Question button, and your question will come directly to us. Okay, let's take the first question. So it was on here and now I see it's not here, but I'm going to ask the question because I thought it was a good one. So when should a child start getting an eye exam? At what age or what time frame?
Yeah, so a child with or without diabetes needs to be screened sort of really when they are in kindergarten, right? And there's several issues why a child might sometimes struggle with school, and vision is one of those reasons. And so any child getting ready to start the next year in school, I think in the summer, it warrants them to get in to be evaluated to make sure that they don't have what we call a refractive error, meaning that light's not focusing in the proper area of the eye that allows us to see well. Oftentimes kids are either slightly nearsighted or slightly farsighted, and that can impact their school performance. The other things that we tend to sort of screen for is what we call strabismus, or basically an eye can deviate in or out, typically inward in children, and that can lead to what we call amblyopia, where an eye won't send information to the sections of the brain that need to develop before about the ages of 8 to 10. And so it's important for children to get in to be seen. Now, if you live with diabetes, typically the ADA recommends that you have about 5 years if you have type 1 diabetes before your first eye exam. And that's because we understand that it takes several years of glycemic instability, elevation in glucose levels that can affect the vasculature to the retina. But essentially, it's a good practice to have an eye exam, once a year, once before starting school, to make sure that we don't need glasses or contacts, or sometimes more aggressive therapy to keep eyes seeing well together.
Okay, thank you. So we have a question coming in from Barbara. Barbara's from Southfield, Michigan. Barbara, you are on the line.
Hi, doctor. I've been struggling with bronchitis. I'm a type 2 diabetic. Do not take medicine because the metformin was too hard on my stomach, so I'm trying to do it with diet and exercise. However, I had a broken foot in May, and then I got this bronchitis, so I have not been able to exercise. And I was put on one of those graduated steroid pills that each day was one pill less. And then after that, I wasn't getting better, so I had another one, and I forget its name, but it was every day one pill for 5 days. And now I'm on albuterol with a nebulizer. And I'm just wondering, some mornings I test my fasting blood sugar, and it was yesterday 200. So I think I still need to be on albuterol, but I'm wondering how much that's going to tamper with my blood sugars. Also, I have been diagnosed with macular degeneration, very beginning stages, but it's scaring me with these high blood sugar readings that I'm getting due to the steroids. But I know.
Yeah, so sorry, I didn't mean to interrupt. So there's a lot to unpack there. So let's start with sort of the low-hanging fruit. Okay, so typically age-related macular degeneration, for those who aren't familiar, is something that can happen to us as we age. Usually we tend not to see it in individuals under 65, but by the time we're 85, 40% or so of those living will have age-related macular degeneration. So essentially what that is that there are cells underneath the retina that wear down. And people tend to talk about a dry form or a wet form. And I try to explain macular degeneration a little bit like the sidewalk in front of my house. We have weak spots that develop, sort of like cracks in a sidewalk. That would be the dry form. The wet form is where blood vessels can grow through those weak areas, causing bleeding and scarring. And fortunately, we have medication that can actually halt and stop that, almost similar to weed killer for dandelions. But I tell people the most important thing about macular degeneration, and probably really just about our vision in general, is when we test vision, it's important to do it one eye at a time. And so make sure whenever you're testing your vision, you're covering one eye and making sure that you evaluate how you're seeing. And a change in your baseline, typically with macular degeneration, it would be distortion and waviness. With diabetes, it could be general blurring of your vision. Is important to check and monitor, because if it's caught early, just like with diabetes, macular degeneration is very, very manageable. Now, typically we tell patients to make sure you're controlling your risk factors. Similar with diabetes, you want to make sure you control your lipid levels and make sure you don't smoke or vape, make sure you're controlling your blood pressure. Now, you brought up a really, really important point that oftentimes we have other illnesses that can affect us. When we live with diabetes and we need to take steroids, it really causes difficulty with our blood sugars. And you're right that, elevation blood sugars in the long term can cause trouble. But it sounds like, at least from hearing your history, which I appreciate you sharing, that making sure that you take care of your respiratory component first, clear your bronchitis, is extremely important, so that you can then oxygenate your tissues and hopefully start to be a bit more active. I know your foot was an issue, but if you can clear the bronchitis, then I think it'll help ultimately long term your overall health. Now, there are other medications than metformin. And so if you didn't tolerate it from a GI standpoint, they do have other classes of medications that you can talk to your doctor about. But in the short term, meaning a few weeks, few months, elevation blood sugars is not going to cause long-term eye damage, right? We see that typically when we've had elevation glucose levels along with blood pressure and lipid levels over years and decades. And so I would encourage you to try to get over your bronchitis. Again, make sure you're on something to help control your blood sugars, and it might have to be something more than just diet or exercise.
Great, thank you. I'm going to go to one more eye question, then we're going to go to some kids' questions that will dovetail into this session of family and children. So This one comes in from Dina. Sorry if I pronounced your name wrong, from Brick, New Jersey.
Thank you for taking my call, doctor. What exams and tests should be done on an annual visit?
Yeah, that's a great question. And so typically when we think about retinopathy, right, what we're talking about is changes that occur to the vasculature in the back of the eye. So if we think of the eye, we tend to break it up into front, or we call the anterior segment, and the back, or the posterior segment. But a retinal image, so if you take a picture of the back of the eye, we can make the diagnosis oftentimes, or a computer can make the diagnosis of changes that happen. So we can see hemorrhages, we can see microaneurysms, we can see cotton wool spots. But that doesn't really give us an overall understanding of the eye health. And so when you go in to see an optometrist or an ophthalmologist, an eye care professional, essentially, they're going to do about 10 different things that will evaluate the overall health of the eye. Now, we think of an eye exam, right? We go in and we get our eyes checked for glasses, and that's part of it, right? Making sure that we have light focusing properly into the back of the eye. But we also want to check the pressure inside the eye, because unfortunately there's a condition called glaucoma that can be associated with oftentimes higher pressure long term, affecting how the eye can then communicate to the brain. We check a visual field test, which is sort of how much each eye sort of sees individually. We'll go ahead and then evaluate all the structures, the lens, which helps focus light, the health of the cornea, make sure that we have good corneal sensation, because as we know with diabetes, long term, it can affect the way we feel, and not only to our extremities and our feet, but you can actually sort of lose sensation to the surface of the eye and the cornea, and that puts us at risk for what we call a neurotrophic ulcer. An ulcer is just sort of a breakdown, if you will, the surface of the epithelium. And so there's a lot to just looking at the structures in the front of the eye, and then we move into the back of the eye, and where I sort of focus is what's happening with the vasculature. So we'll take photographs oftentimes, and there's different types of pictures, like a color picture that you can see. There's also a cross-sectional image that we call an optical coherence tomography, or an OCT image, that measures the amount of thickness. Because when we talk about retinopathy, you can really break it down into two different sort of pathways. One where it affects the circulation, and that can shut down blood vessels, right? And if we become ischemic, oftentimes we'll try to grow new blood vessels, which you would think that would make sense inside the eye. That tends to cause hemorrhage and scarring, which we want to basically stop if we see those blood vessels forming. But we could also have blood vessels that are naturally there, leak fluid and cause swelling, and sort of like a sponge becoming swollen. The retina can't function as well. So oftentimes we have medication to sort of reduce what we call macular edema, or swelling within the center of the vision. And then from there, depending on the health of the optic nerve, sometimes your physician might do a visual field test. So there's really, if we really had to break it down, it's not just simply making sure you can read letters on an eye chart. It's making sure the overall general health of the eye is important. And really, if you take home anything from tonight's lecture, it really should be that retinopathy is something that can happen without us really noticing it, right? And oftentimes we'll see, when we break it down, we like to rate things mild or moderate or severe. We can see sort of moderate or severe stages of retinopathy that are occurring before we start to lose vision, right? And unfortunately, once we get to a certain point, sometimes we can't reverse some of those levels. But with our treatment, we're able to improve things a few sort of steps. So we can take somebody from severe back to mild. Again, you got to be able to sort of get in to be evaluated. So just annual eye exams are so critically important.
So could you break down, if a person is under the age of 15, for example, they were diagnosed 5 years ago with type 1 diabetes, and this is their first exam, how would it differ from that discussion?
Yeah. So typically, if we're going in and we're getting screened and we see well on an eye chart, oftentimes, a physician might, take a look into the back of the eye without having to dilate the eye. But if you've, lived with diabetes for 5 years now, then you're going to need a good dilated exam. And so typically I tell people it's a little bit like I can peek through a keyhole in the door, but I'm going to see much better if I open the door wide open. And so we'll use eye drops that will basically, for about 4 to 6 hours, dilate the iris so that we can see the structures in the back of the eye. And then there's what we call a slit lamp exam. A slit lamp is a microscope that we can see various surface structures as well as deeper structures with certain lenses into the back of the eye. And then an indirect ophthalmoscopy where we have sort of a little headlamp that sort of sits on the surface that allows us to focus light into the back of the eye to evaluate the surfaces. And if we really look into the back and we see no evidence of retinopathy, then typically we'll have somebody come back in a year or two, depending on what their glycemic stability is. Usually I tend to tell my patients it's best to come back every year. But, again, ADA guidelines are such if we have good glycemic stability that, again, probably, every year to 2 years is reasonable as long as there's no signs of retinopathy. But when we talk about staging levels of retinopathy, essentially we're looking for things like microaneurysms and cotton wool spots, areas of retinal edema that basically take us through different stages. And if we start seeing evidence of retinopathy, then we oftentimes might even have to have patients come back a little bit sooner than every year.
Thank you. So, Chris, I'm going to ask you some questions about kids getting ready for school because we want to look at the family and children as well. So, when kids are getting ready to go to school, regardless of their age, let's say up until the age of college, what are the things that they need to make sure that they check off their list when it comes to forms to have to share with school, and who at school should know they even have type 1?
That's a good question. I think maybe an oversimplified answer would kind of work under the assumption that all of our kids are in public school or that all of our kids even have a school nurse. But we know that that's just not the case. And so I think you want to identify first who at school is going to be kind of that primary touch point for diabetes. Maybe it's a school nurse. Maybe it's what I affectionately refer to as the lady in the front office. That's what we had for years and years. My son went to a small little private school. There was no school nurse, but that individual was just so loving and so caring, and I couldn't have asked for anything better. The diabetes medical management plan, I think, is kind of your first and foremost your primary document that you're going to want to take to school. Some schools require it, some schools do not. That also varies from state to state as to which documents are legally required. But the diabetes medical management plan is going to give instructions to the school from the provider's perspective as to how we expect for them to care for our kiddos when they're at school. Then you kind of start getting into the weeds a little bit, not so much with medical orders, but with accommodations, unwritten expectations. You dive into the wonderful world of cell phones and technology and what's allowed and what's not allowed. The 504 meeting is so important for many of our kids because they are using all of this technology, and if it's not allowed in the school, then there needs to be some sort of conversation, an official conversation that gives them the access to the technology without any sort of punishment down the road. Now, if our kids abuse those opportunities, they have a cell phone and they're not actually checking their blood sugar with their Dexcom or something, or their glucose levels, but they're actually, maybe on YouTube or something. That's a whole different story. But I think we need to set them up for success. The DMNP, the 504 meeting with the 504 documentation are probably the two most important ones that I can think of right off the bat.
And I think defining that the 504 is an agreement with the school. So it's not something the doctor fills out. It's actually the school personnel that help you fill that out, whether it be a school nurse or a principal or whatever, correct?
No, that's pretty much spot on. Where the provider comes in is that we will often give recommendations for what accommodations should or need to be made. And then the caregiver would take that back to the school, oftentimes with a school counselor, maybe the principal, definitely the school nurse is involved in that. And they actually sit down separate from any sort of meeting or conversation with the provider, and they determine what accommodations will actually be made.
Great, thanks. So I have a question for both of you because I'm a campaholic. I love having kids with diabetes go to all sorts of camps, whether it be surf camp or residential camp or whatever. So, Dr. Cooper, let's start with you. Did your daughter ever go to a diabetes camp? Did she like it? Did she hate it? What happened with that?
That was a great question. So she did not go to diabetes camp. She was the child who had diabetes or has diabetes and wanted to make sure that she was able to do everything her friends were doing, right? And so I think that I would have loved her to have gone to a camp. The closest she got to that was she was part of the JDRF Children's Congress, and so she went to DC and spoke in front and testified in front of Congress. In 2015 or so, and that was a wonderful experience for her to be around other kids with diabetes. But short of that, I think we were just so into other things that she was doing outside of just diabetes that it was hard to sort of encourage her to do that. She really probably would have benefited, I think, in some ways from it, because she's not the kid who likes to really go up to her professors or her teachers and say, I have diabetes, I have this device, and I'm going to need to be able to check my blood sugars every so often, or if I'm feeling low, pause my test to be able to sort of take some glucose. So I'm in full agreement with Chris that having a plan in place that your child doesn't have to sort of figure out on the backside of things is going to be important for success for your children.
Chris, what about you? Did your son go to any kind of camps, or have you sent a lot of kids to camps, or what's your feeling about diabetes camps?
Oh, goodness. How long do we have? My son is 17 right now, and he went to his first diabetes camp when he was 7. And I'll have to say the first year was somewhat traumatic. And I think parents would benefit from hearing this sentiment. But my wife and I, drove him up to Northeast Georgia. It was about 4.5 hours from where we live. And we just did what we knew to do. We dropped him off, and he cried his face off for a couple of days. And so I felt like the worst dad ever, honestly, because I dropped him off. He has diabetes for I don't know, it was about a little over a year by this point. So it wasn't new, but it was, looking back, it was definitely new. But we dropped him off. He cried. And when we picked him up, I saw his bus pull up, and they got off the bus, and he was crying. And I went up to the camp director and I said, has he just been crying for 6 days straight? She goes, no, he's not been crying for 6 days straight. And what she said was just absolutely beautiful. She said he cried the first 2 days because he missed you guys. And he's crying now because he doesn't want to leave his friends. And I think that is the value of diabetes camp. And I just about cry every time I tell that story, because he realized there were other kids just like him, and this was the one place where diabetes was not central. I mean, even having a diabetes camp, they could just go there and be kids if they wanted to go kayaking or canoeing or rope climbing or whatever else. Someone else was handling diabetes for them. So I'm a huge fan of diabetes camps. I tell you, with our center, we used to be a part of a large hospital system, and we had all sorts of funding. And we sent 30 kids to camp every single year at no cost. And we are trying to get back to that point. We developed a nonprofit just specifically for that. And so our hope is in the next couple of years, we can get back to, removing the cost of diabetes camp, because it's such a big hurdle where we are. We have a lot of lower income families. And so I just believe that every kid should have the opportunity to go. Now, he's 17 now. And he has kind of like what Dr. Cooper shared. He's kind of trailed off from diabetes camp. He's going to basketball camp. He's getting older. He's doing what a lot of his buddies are doing. And so, no, camp is not a part of our life as much as it used to be. But because of his experience when he was 7, I actually started volunteering at camp. And now I've been to camp more times than he has. So yeah, camp is an interesting topic in our house for sure.
So Carla, can I ask a follow-up question to that?
Yeah.
Or at least it might be spiraling away from camp a little bit, but so you have a 17-year-old, Chris. How was driving for you guys? And what do you do when you get ready to let your individual with diabetes leave the house for the first time with the car keys?
Oh, well, I can tell you, we had lots of conversation about that before he started driving. Um, I told him, I know that things are going to happen and that we don't live in a perfect world. You are going to go high, you are going to go low, but I do expect you to do it safely. So if you realize you are dropping and that you're about to have a low blood sugar, by whatever means, if you stopped and checked because you felt funny or because your alert went off on your CGM, I expect for you to pull over. And day one, day one, he's driving. And he also knows that I have an app on his phone where I can see where he is at all times. He doesn't know that I don't actually look at it that much. But
Yeah.
day one, he called me and he said, Dad, I know you're probably tracking where I am because this is the first day of me driving ever. And I know I said I was going to so and so's house, but I just pulled off in the mall parking lot because I had a low blood sugar, and I just wanted to let you know. So communication, communication, communication has been the driving force behind a healthy relationship with diabetes and maintaining sanity in our own home. Because without communication, we're always wondering what he's doing. So honestly, I know that not every family communicates well, and we've certainly had our moments where we don't. But I have to give him credit where credit's due. He's a very good communicator, and he kind of knows what I'm thinking because I've drilled into his brain for so many years. But he's a pretty safe driver. He's a pretty safe driver with diabetes, but he will pull off the side of the road. If you look in the back of his car, he has what I'll just refer to as mountains of sugar. Okay, and he doesn't abuse it. He doesn't. I mean, I'm sure he's grabbed one every now and then, just for fun. But for the most part, they get used just for low blood sugars. But he has just cases of his favorite drinks. Um, he's a little bit over juice boxes after 11 years with diabetes. But yeah, that's been interesting for sure. I think the anxiety has finally subsided on our part with not just him driving, but him driving with diabetes.
Yeah.
Well, and I think it's a good point that everyone should know where their blood sugar is if they have diabetes and they're taking any kind of medication that can lower it. They need to be checking. And we have the other piece of teens driving, which is scary for everyone, regardless of if you have diabetes or not. But it just adds another element of concern. So thank you for sharing that. One last question about kids. We're getting a lot of questions in about ophthalmology, and we'll get back to that in a second. Not necessarily children, but families and people that have diabetes. Chris, who else at school besides maybe the teacher should know when a child has type 1 diabetes? You mentioned the gatekeeper kind of person, whether it's a front desk person or the nurse or whoever they happen to mark out. But who else might be? I mean, do coaches need to know? Bus drivers? Who else needs to know?
That's not skirting around the answer to the question. I think that's really individualized because, again, all schools look a little bit different. Um, whether they're in elementary school, middle school, high school, certainly there's a level of independence with a high schooler that you just don't have with an elementary schooler. But the simple answer, I would say, is as many people as possible without making life about diabetes, right? We never want to put diabetes right in the middle, but we have to maintain a high degree of safety. So the school nurse, for the younger kids, they're not necessarily swapping classrooms that much. So I would say, that one primary teacher that's in charge of them, as they get a little bit older, middle school years, they tend to work in pods or teams where they're rotating through 2, 3, 4 teachers. All the teachers, I think, need to know. I don't know if it matters that the principal necessarily knows if the principal is not someone who is typically inserting themselves into these 504 meetings or any sort of situation related to diabetes. The counselors often will want to know that. Coaches, that's a big one in our family because we're a big sports family, and every coach I've had a conversation with at the beginning, and I have a tackle box that just, I don't know, it just travels with us from year to year, school to school. And each of the coaches have a tackle box. And I give it to him and I say, listen, here's what's in it. I just want you to know. I know it probably scares you just a little bit to talk about maybe a worst case scenario, but you need to know he has diabetes. But he'll also communicate things with you, and he'll be fine, But as many people as possible. I do think it takes a team. It takes an entire army to make diabetes happen. And honestly, one of the parents' worst fears is the fear of fear, right? We're sending our kids off to school. We're assuming they're being well taken care of, but the truth is, some days we just don't know. We just don't know. And even if they're wonderfully taken care of, it's that anxiety, it's that frustration. It just follows us everywhere. It never leaves us alone. And so I think one way to decrease frustration, decrease anxiety, is to communicate and to grow the diabetes team while they're at school.
Great. Thank you. Okay, we're going to go back to some ophthalmology questions right now. And Michelle from Jefferson, New York, you are on the line.
Hello. Glad you took my question. I have a question that has to do with rosacea of the eye. I don't know if it exists. I read about it in a book that had to do questions and answers about diabetes, and that was the only time I ever heard about it. And I have questioned other professionals, and they don't know what I'm talking about. So I was just wondering if this is something that it does occur. They said it was a question about a person having rosacea on their face, and that it occurred also in their eye. And I have tremendous dry eyes, problems with it. And I take different drops and things like that. But I even seem to suffer more than a lot of people. And so I'm wondering if I could have something called rosacea of the eye.
Yeah, it's a really good question. Can I ask just a quick follow-up to that?
Sure.
Do you have trouble with dryness as well as the mouth when you're chewing and
Oh
swallowing?
yes. Definitely, everything is dry.
Yeah,
77 years of dryness.
Yeah, so essentially there's, at the base of each eyelash is a gland that we call the meibomian glands. And they create one of the three components to our tear film. So there's an oily component, a fatty component, and a liquid component. So most of the time, one of those three components is off. And if we have rosacea, it affects those glands. So those glands can't make one of the three areas that help mix together properly. And I tell people it's like baking a cake without sugar or flour. It just isn't going to turn out right. You need all of the components there to mix properly to basically lubricate the surface of the eye. And when we have diabetes, as I mentioned sort of earlier, we can develop problems with the way the nerves work. And we may actually, if we have dryness, get into a problem where the epithelium or the surface of the eye breaks down, and that can create a very dangerous situation where you can get an ulcer on the surface of the eye or an infection. And so keeping your eyes lubricated is extremely important. But oftentimes, if you also have dryness of at least your, sort of mucosa, especially within your mouth, then you might want to make sure that your physician's checking you for Sjogren's disease. It's an autoimmune condition, as we know with diabetes. Oftentimes we can have more than one autoimmune condition. If we're having really severe dryness and dryness in the mouth, you might be checked for Sjogren's, and there's some treatment for that.
Okay, thank you very much for that. Okay, so now we have a question about, let's see which one I want to pick next. So this one comes from Sherry. Sherry is from Austin, Texas. Sherry, you're on the line.
Yes, hi. I had a blood vessel that broke in my right eye about a month and a half ago, and I still see like blood droplets floating around in my eye. But the doctor had put in a shot into my eye. I was wondering, can this happen to my other eye? Do you know? Or I've had diabetes for 57 years, so I'm a type 1.
Yeah. So first off, congratulations for living with type 1 diabetes for 57 years. That's really quite a feat. I know. To answer your question in short, yes, it can happen to the other eye. However, it sounds like your doctor already has you on the appropriate therapy. So let's back up a little bit. When we talk about diabetes affecting our eyes, it oftentimes affects the circulation. So it can, like I mentioned earlier, shut down part of that circulation. So the body tries to grow new blood vessels. That's what we call the proliferative form of diabetic retinopathy. And when we start seeing those blood vessels grow, they're very immature. They don't quite carry blood into the right area, and they tend to break open and bleed. And the back of the eye is filled with a gel that we call the vitreous. So it's almost like if you were to drop food coloring into a water balloon, it would sort of disperse within the container. When we get bleeding into the vitreous cavity, the first thing we want to do is get that process to stop. And so we have essentially several different medications we can inject into the eye safely that allows those blood vessels to regress and get the blood vessels to stop bleeding. And then the hemorrhage will have a chance to clear. And so I'm sure your doctor, when you were in having your eye evaluated, looked at the other eye for those new blood vessels. And if we see them growing, oftentimes we'll treat both eyes actually to help regress blood vessels and allow the hemorrhage to clear. Now, a non-clearing hemorrhage can be removed with surgery, but oftentimes if we sleep slightly elevated, allow the blood to settle, with time, that hemorrhage should clear and your vision should hopefully improve. But the injections, unfortunately, they're not just sort of one shot and you're done. Oftentimes, I tell people it's a little bit like our gas in our cars. We have to stop every so often and get the gas tank filled back up. Oftentimes, as blood vessels regress, they can come back if they're not treated, either with medication or sometimes even some laser treatment put in place to help stop those blood vessels from reforming.
Thank you. As a reminder, we just have a few more minutes for questions. For those of you on the phone, press *3, that's *3 on your keypad, and an operator will collect your question and place you in a queue. To participate online, type in your name and question in the fields below the stream player and press the Submit Question button, and your question will come directly to us. So we want to make sure we're getting your questions, particularly about family and children, but also about eye care. So
I have a quick question about
yeah.
family, and if you don't mind. So, Chris, your son is a junior, right? And probably thinking about colleges. And how are you going to prepare him to go off to college with diabetes?
Oh goodness, that's. I think
I'm sure you thought about it.
Practical. It's practical ways to answer that question in terms of what tools will we send with him. What conversations will we have with the college, with wherever he goes, whatever medical department they have. I think there are also questions of the heart too. And I've often said, when you're in my house, I can control some of your actions, but I'm never in charge of your heart. And so when he goes off to college, I think that what I'm most concerned with is that he knows the difference in right and wrong in general, but also with diabetes, you have to make hard decisions on the fly. Maybe your friends are doing some things that like if you do that, it is just not going to go well at all. And so my goal is to make sure that he's prepared to be in those tough situations to manage his diabetes. But I think it comes down to the heart. Once they're gone, they're gone. I have a friend who she is a diabetes educator, and her son is a little bit older than mine. I think he's 21 now, but he has type 1 diabetes. And it was funny because we were both in the wonderful world of diabetes, both have sons, hers a little farther ahead of mine. And I told her, I said, you got to back off from him. You got to trust your training, trust his training, and just let that little bird fly. And she did not take the advice. She knew better, but she constantly called him and texted him. And do you know what he did? He deleted her from his Dexcom app, just out of the blue, just deleted her. And he said, leave me alone. I'm fine.
Yeah, it's an interesting sort of time that you're going through. So, and at 18, they're adults, right? I mean, and they need to know that they need to get their eyes looked at once a year, that they need to, they assume that responsibility, and they end up in an ER. They can't call mom and dad. They're the adult at that point. So,
Right. So, Blake, can you give Chris some advice, having gone through that time where your daughter transitioned to college? What did you do?
Yeah, no,
Yes, please.
it's just sort of interesting. So, it was one of those things, and the reason I use that example is, we got a call from one of her roommates saying, first off, Amelia's okay, and this was 2:30 in the morning, right? And we've been very fortunate. So all along, Amelia's had access to technology and medication, and I know a lot of people aren't that fortunate, but she's been very, very fortunate to have access to a Dexcom, right, a continuing glucose monitor, and her parents were able to follow her as well. But we did make the conscious decision that we're not going to follow her every single night and call her if she's low. But for a while we would just sit there and we'd watch her blood sugar drop, and then we'd wait. And then we wait, and you know what that's like is, you're just sort of waiting for things to come back. And in her first year, she was not on a closed loop system. So she had a Omnipod and a Dexcom, and this was before Loop was available. But basically May of that first year of college, we had sort of did a do-it-yourself Loop system that got her to close that gap, and that really helped with her lows at times. But she's an adult, and she went into an ER one night, hypoglycemic, and was fine. She needed some glucose, and she had, all of her friends had glucagon pens and knew what to do, but they were smart enough to call for help when she was low. But it's sort of scary, right? And I think you hit it on the head. When you have a child that you've raised, it's hard to let go. It's hard to allow them to make mistakes, especially with diabetes, right? And because mistakes can be really, really severe. But having that trust and having the communication and having them prepared for what could happen is important. And she's grown from that experience. And sort of as Carla mentioned, she started medical school today, and that wouldn't have happened without diabetes, right? I mean, I think that her interest in medicine would not have happened if she didn't have to learn at an early age, how to count carbs and how to manage herself. And I think that kids grow up really fast in many different ways, right? And I think with diabetes, they assume a lot of responsibility, and they carry forward that in school, and I think they'll succeed because of it. So but it's a hard first semester, right?
Well, and it's really challenging to send any child off to college and hope that they make good choices, and then you add the type 1 diabetes twist to it. It makes it even more of a little challenge on letting go, and it makes it a little more challenge on them too, to take a little bit more responsibility for themselves. So this wraps up our go ahead.
Just real quick, is that I think one of the biggest struggles that I see in our practice is that parents don't have a plan for backing away. And maybe that's about diabetes, maybe it's not. But in terms of diabetes, I'll tell you something practical, since we're just kind of chit-chatting here. Something practical that I did this year, it's probably about 6 months ago. I realized that we were talking about diabetes in our house way too much. And so I told him, I said, buddy, I really do trust you in most areas. And in the areas where I don't, we're just going to keep having lots of conversation. But with diabetes, I pretty much trust you. And it's not that I want to remove myself, but I know that we're talking about it too much. And so when you walk in the house, I don't want to say, hey, how are your blood sugars today? How was your glucose level today? I just want to say, hey, how was basketball practice? I said, so what I'm going to do, I'm turning off all of your alerts on your CGM, except for your urgent low alert. Everything else is turned off. And he didn't believe me. He came in 2 weeks later and he goes, Dad, I'm sorry. I know I've had a crazy couple of days with my blood sugars, and I didn't give all the insulin I was supposed to give, and I missed a bunch of boluses. And I interrupted him. I said, buddy, I don't think you understand. I turned off all of your alerts. I have no idea what your blood sugar has been the past 2 days. And so I think having that plan for slowly, strategically backing away from them is going to go well for people. It prevents you from revolving the rest of your life around diabetes. I think for a season maybe you need to, but then you got to have a plan to back off. Just be normal, feel normal, not give diabetes too much credit, but give it what it needs.
It's great advice.
Great advice. So thank you both so much. We're out of time for questions. I do want to put in a little pinch for Safe at Schools on July 28 at 2:30 p.m. Eastern Time. There'll be a Safe at Schools Back to School panel roundtable discussion. It'll bring together the expertise of professional members, including members of the ADA Safe at School Working Group, to help parents, school nurses, and staff and providers and others prepare for the upcoming school year. So you can register at diabetes.org/safe at school. Again, that's diabetes.org/safe at school. So to help you feel confident about your ability to prevent and treat diabetes-related eye disease, we encourage you and your loved ones to schedule an annual dilated eye exam, whether your child has symptoms or not, and that's true of you as adults as well. Make sure your child has a medical management plan. Talk to your school about securing a 504 plan, and register for our next event at diabetes.org/experts. All these links are on the Ask the Expert registration webpage, diabetes.org/experts. We're sorry we were unable to get to your questions during this live Q&A. If you have questions about this event, you're welcome to contact us at askada@diabetes.org or by calling 1-800-DIABETES, which is 1-800-342-2383. We are here to help you with your diabetes journey. Special thanks to our experts, Dr. Cooper and Chris Britt. I am Carla Cox, and on behalf of the ADA team, we want to thank you for joining us today, and we look forward to connecting with you on our next Ask the Experts event. The focus on diabetes, more eye health, September 27 is Ethnic Differences, Does Race Matter in Diabetes Eye Disease? And then also No Diabetes by Heart, August 9, Transitions in Care. Additional questions can be email and additional questions to askada@diabetes.org and include the Ask the Experts Q&A in your subject line. Please stay on the line for a quick survey, and if you have additional input for future events, please let us know. If you have added ideas for family and children events, please email me at ccoxctr@diabetes.org for type 1 and family topics you'd like to see covered. So we'll now start with our survey. Please stay on the line to join us. Thank you for participating in the American Diabetes Association Ask the Experts event. We hope that you benefited from your experience. Please stay on the line to complete a survey about the event. Your valuable feedback is essential for us to reach our program goals and improve future events. All responses remain confidential. Question 1. Please rate the extent to which you felt the event met your expectations. For did not meet my expectations, press 1. For somewhat met my expectations, press 2. For moderately met my expectations, press 3. For met my expectations, press 4. And for exceeded my expectations, press 5. Again, the question. Please rate the extent to which you felt the event met your expectations. For did not meet my expectations, press 1. For somewhat met my expectations, press 2. For moderately met my expectations, press 3. For met my expectations, press 4. And for exceeded my expectations, press 5. If you feel you could use some support for managing your diabetes, check out the Living with Diabetes program, where you can receive information through email and e-booklets with tips on eating, physical fitness, and emotional health. Check out our registration page, diabetes.org/experts. Okay, now on to question number 2. After attending this event, do you plan to attend a future Ask the Experts event? For yes, press 1. For no, press 2. And for not sure, press 3. Once again, question number 2. After attending this event, do you plan to attend a future Ask the Experts event? For yes, press 1. For no, press 2. And for not sure, press 3. Persons with diabetes are at higher risk for retinopathy than those without diabetes. Make sure to have your annual eye exam. Early detection can save your vision. All right, now we go to question 3. Please rate your agreement with the following statement. By attending the event, I gained knowledge on the presented topic. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Again, question number 3. Please rate your agreement with the following statement. By attending the event, I gained knowledge on the presented topics. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. You can find delicious and healthy recipes and menus to enhance your eating. Check out the website www.diabetesfoodhub.org, and I have visited that several times and really enjoyed it. So that is www.diabetesfoodhub.org. Okay, question number 4. Please rate your agreement with the following statement. The knowledge I gained is relevant to my or my loved one's diabetes. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. That question again. Please rate your agreement with the following statement. The knowledge I gained is relevant to my loved one's diabetes. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Did you know that there are approximately 37 million Americans with diabetes? You are certainly not alone. All right, we are now to question 5. Please rate your agreement with the following statement. I feel confident that I can apply the knowledge I gained to help manage my loved one's diabetes. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Once again, question number 5. Please rate your agreement with the following statement. I feel confident that I can apply the knowledge I gained to help manage my loved one's diabetes. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Check out the heart disease risk calculator at https://www.cvriskcalculator.com and discover if you are at risk for heart disease. That is www.cvriskcalculator.com. Okay, now on to question 6. Please rate your agreement with the following statement. I intend to use the knowledge I gained in a new or future appointment with a healthcare professional. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Once again, question 6. Please rate your agreement with the following statement. I intend to use the knowledge I gained in a new or future appointment with a healthcare professional. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Did you know that there are approximately 250,000 persons in the United States with kidney failure related to diabetes? Talk with your healthcare provider about your risk. Get tested and prevent diabetic kidney disease. Okay, question number 7. We just have a few more left. Please rate your agreement with the following statement. Attending this event promoted my feeling of belonging and community. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Once again, question number 7. Please rate your agreement with the following statement. Attending this event promoted my feelings of belonging and community. For disagree, press 1. For somewhat disagree, press 2. For neither agree nor disagree, press 3. For somewhat agree, press 4. And for agree, press 5. Physical activity is an important part of reducing the risk of cardiovascular disease and promotes psychological well-being. If you are finding movement challenging due to injuries or chronic pain, ask for a referral to a physical therapist to work with you to find a program that works for you. And there is even some information that physical activity may help your eye health as well. Okay, we're going to ask a few questions on our demographics. We strive to create programs and services that represent the full diversity of the ADA community. We are asking the following questions about demographics to ensure that we are meeting this goal. So, please select which of the following best describes you. For a woman, press 1. For man, press 2. For non-binary, press 3. And for prefer not to answer, press 4. Again, our gender question is, please select which of the following best describes you. For women, press 1. For man, press 2. For non-binary, press 3. And for prefer not to answer, press 4. Keeping your glucose within the target range of 70 to 180 milligrams per deciliter 70% or more of the time is the international recommendation for diabetes management. Considering asking your provider about getting a continuous glucose monitor to help you manage and monitor your glucose. Okay, now we have a question on generation. Please select which of the following best describes you. For silent, born between 1928 and 1945, press 1. For boomer, born between 1946 and 1964, press 2. For Generation X, born between 1965 and 1980, press 3. For millennial, born between 1981 and 1996, press 4. For Generation Z, born between 1997 and 2012, press 5. Or prefer not to answer, press 6. So once again on generation, please select which of the following best describes you. For silent, born between 1928 and 1945, press 1. For boomer, born between 1946 and 1964, press 2. For Generation X, born between 1965 and 1980, press 3. For millennial, born between 1981 and 1996, press 4. For Generation Z, born between 1997 and 2012, press 5. And if you prefer not to answer, press 6. Okay, we have one more. We hope you enjoyed this Ask the Expert program. Will join us again next month for another session. Check out our schedule on diabetes.org/experts. Okay, our last request of you is to give us your race ethnicity. Please select which of the following best describes you. For African American or Black, press 1. For American Indian or Alaska Native, press 2. For Asian or Asian American, press 3. For Hispanics, Latinx, or Spanish origin, press 4. For Middle Eastern or North African, press 5. For Native Hawaiian or Pacific Islander, press 6. For white, press 7. And for prefer not to answer, press 8. Again, our final question. Please select which of the following best describes you. For African American or Black, press 1. For American Indian or Alaska Native, press 2. For Asian or Asian American, press 3. For Hispanic, Latinx, or Spanish origin, press 4. For Middle Easterner or North African, press 5. For Native Hawaiian or Pacific Islander, press 6. For white, press 7. And for prefer not to answer, press 8. Thank you for answering these questions. Please join us again at future Ask the Experts events. To learn more, go to diabetes.org /experts. Again, that is diabetes.org /experts. And good evening.